Thank you very much. So I'd like to introduce Dr. Wade, who's an associate honorary professor at Royal Free, who is a consultant health psychologist, looking in particular at the impact of critical care and its treatments on risk factors, outcomes and interventions. So, Dr. Wade.
Good afternoon, everyone. It's a great pleasure to be here. Thank you for inviting me. I'm not a neuropsychiatrist, but I'm a health psychologist. And health psychologists are people who are interested in the psychological aspects of ill health, and healthcare settings and systems. And in my case, I became very interested in the psychological impact of being in intensive care. So my talk is about the psychological scars of intensive care. And I think, as you'll see, in keeping with the title of the session, being in intensive care is indeed a very extreme situation. So we'll be covering psychological recovery after intensive care, the risk factors and the role of acute stress and the impact of that on your recovery, the role of health psychology both in clinically working with intensive care patients and also carrying out research to develop new psychological interventions for intensive care patients. As this BBC News headline said, intensive care has psychological impact on many, and that includes the patients, of course, but also the family, friends, support network of the patients, and the staff who work in intensive care. This talk is going to focus on the patients, but it's just worth knowing that research has also been carried out with family, finding out that they have high rates of anxiety, depression, and even post-traumatic stress disorder after going through the experience of witnessing their loved one in intensive care. And intensive care staff, a lot of research has been carried out showing that they have very high stress rates, more than other healthcare workers, which are already quite high, and are at risk of burnout and also post-traumatic stress disorder themselves. But there's a huge body of work on each of these groups, so I'm just going to focus on patients given the time we've got today. Okay, I always like to start these talks with a patient's story, so it just focuses us on the main point of how people experience being in intensive care. So we're going to see a very short video of Alison. Alison was a young woman who was involved in a car accident. She's a marketing executive in a pharmaceutical company. When she had the car accident, she was sort of taken by helicopter ambulance to hospital. Unfortunately, she was left in a ward for a couple of days and it wasn't noticed the extent of her external injuries, so she was really deteriorating fast and then had to be rushed to intensive care. So we'll just hear a little bit from Alison.
I remember waking up. I remember not really knowing where I was. All I could see were other patients. And my memory of the reason I was there was not from a car accident. I thought I was there because I'd been kidnapped, because I'd been raped, tortured. And as I looked around, I thought I was in an experimental laboratory. I could see a patient with a cage around their head. I could see another elderly lady in a bed, and I could see blood just flowing out at the bottom of my bed. And I was looking for the face of the murderer, because these people have faces and they have names. But then I heard a voice, and it was a nurse, and she just smiled at me. And she said to me, "Your parents are going to be so pleased to see you awake." And at that moment, there was just the enormous sense of relief because I just felt safe. I didn't really know I was in hospital. I didn't know I was in intensive care. I just knew I'd been rescued. I wasn't telling them about the nightmares. I wasn't having a wink of sleep. You don't come out of intensive care and sleep. It's an impossibility. Your brain doesn't work, your mind doesn't work, your body doesn't work. You can't even think straight. And I remember that evening as my parents left, they would come in every single day to see me from midday to about 7 o'clock and stay with me, sit with me, talk to me. And when they left, I realised that it wasn't necessarily guaranteed that I would get out of that hospital alive. I realised that there was no point in me crying. It was a case that I just had to trust the doctors, trust the medicine, and play my role and try as hard as I could. I wouldn't let my friends come to visit me or my family. I was scared that if they saw me, it would be real. I was scared that if they saw me, I wouldn't be able to hide the reality and keep a brave face and just focus on getting out of hospital. And I've apologised to them since. But I was also scared that I wouldn't make it, and I didn't want them to remember me like that, as an emaciated, frail, broken person. That's the hard part, because getting out of hospital had been the focus, but actually getting out of hospital was then also about facing reality, because I'd avoided seeing myself for the duration of hospital. But getting home, I realised I was far from well. I was far from being the person I was. I wasn't working. I didn't look like me. I couldn't speak properly, so I didn't sound like me. I was unable to do anything that the old me could do. So I had no identity, no purpose, and that's hard. And at the same time, I was trying to deal with all my memories, trying to process what happened, trying to understand it. I wasn't sleeping, I was having nightmares.
So I think Alison is a good example where the psychological scars aren't always obvious. She's obviously a very well-presented young woman, but she has really struggled with post-traumatic stress disorder, as well as the results of her, physically, from the results of her internal injuries. And unfortunately, Alison's is far from being a rare case. Clinicians now talk about post-intensive care syndrome, which was a sort of new syndrome that was coined about a decade ago, 12 years ago. And it was recognizing that while survival rates from intensive care had hugely improved, the quality of recovery often wasn't very good. And a whole series of impairments were there that would really limit people's quality of life. And also, it was a huge burden of care on families and other carers. So this consisted of physical impairments, particularly respiratory and musculoskeletal problems, cognitive impairments such as problems with memory, concentration, executive function, learning, using language, and also psychological difficulties. So going a bit more into the psychological difficulties, there are quite a number of meta-analyses, well-conducted meta-analyses and systematic reviews, which show a consistent picture of psychological difficulties going on for at least 6 months, and in fact, sometimes for years. So at 6 months, about 30% of people will be having serious symptoms of depression, 40% of anxiety, and around 20% of symptoms of probable post-traumatic stress disorder. Similar results were found in a cohort study in the UK of nearly 5,000 people in multi-centres, And they found that more than half of intensive care survivors were experiencing either anxiety, depression, or PTSD at both 3 and 12 months after intensive care. And more than a third were, showing symptoms of more than one of those outcomes. These are the charts from that cohort study. So at the top, you can see with anxiety, depression, and PTSD. On the left-hand side, you see the 3-month results, and on the right-hand side, the 12-month results. And you can see that those problems haven't diminished over time, and in fact, they have slightly increased. Other outcomes that have been measured include cognitive difficulties, and studies have found more than a third of patients having cognitive difficulties along the lines I mentioned before at 3 months. Quality of life and functional status have been measured and been found to be reduced. And not surprisingly then, 40% had not returned to work at the end of a year after leaving hospital in that study. Other outcomes of interest are, this is something we see clinically to a small extent, that there do seem to be some patients with persistent delirium and persistent hallucinations or delusions. That's not really something that's been measured in research and something that we'd like to look at. But of course, there are very many people who also have a very positive recovery from intensive care, despite the gloomy picture I'm probably painting. A lot of people say, they're so grateful to the staff that their life was saved. And some of them say, it's like a second chance and a new lease of life. And they, really use that experience to sort of develop new things in their life. So it's not all bleak. These are some of the risk factors that have been identified in those meta-analyses for poor psychological recovery. Sedation practices, especially use of benzodiazepines. Now, this refers to patients being sedated in order to be mechanically ventilated in intensive care unit. Traditionally, benzodiazepines such as midazolam were used, on a longer-term basis than those drugs would normally be used for to sedate patients. But I think we've now realized that that's quite a harmful practice for patients. But generally, the longer patients are sedated, the more likely they are to develop PTSD, for example. Delirium, which I'm going to talk about later, is another risk factor for poor psychological recovery. And certain types of memories, early traumatic memories of either real events in ICU or of hallucinations and delusions that patients have in ICU, also predict PTSD and other psychological difficulties. Neuropsychiatric history, so patients with conditions like Alzheimer's are more likely to suffer delirium, and patients who maybe had not yet quite moved into a phase of dementia now, that can be triggered by being in intensive care. Socioeconomic deprivation is another risk factor, and then one of the major risk factors that's emerged from studies is the patient's experience of acute stress while they're in intensive care, and that's that's a risk factor that's independent of their prior psychiatric history. Just that experience on itself can predict poor psychological recovery. Doctors and nurses had been writing about the way their patients seemed to be reacting almost since the days when intensive care started, which was about 60 years ago. So there are quite a lot of papers going back over 60 years documenting all these reactions, where the patients were very anxious or stressed, having panic attacks in intensive care, others being quite withdrawn and very low in mood, others being very agitated and angry. Insomnia, which I think Alison mentioned a lot, it's very, very hard to sleep in intensive care, and people having really frightening nightmares, feeling confused and having hallucinations and delusions. Is intensive care like torture? Now, this is something that's spoken about. So this Hugh Montgomery, professor of intensive care medicine at UCL, spoke about this in The Guardian. If you think about the sort of things used for torture, you will experience most of them in intensive care. As a patient, you're often naked and exposed. You hear alarming noises at random times. Your sleep-wake cycle is disrupted by being woken up for medical procedures through the night. You'll be given drugs that could disorient you, and you'll be regularly exposed to discomfort and feelings of threat. And in fact, that's something that had been discussed in the nursing literature since the 90s, and intensive and critical care nursing had run a series called Preventing the ICU Syndrome, or How Not to Torture Your Patients. Personally, when I talk to intensive care staff, I don't really like to bring up this issue that this might be like torture, because I think it's hard enough to do their job. And obviously their aim is not to torture their patients, their aim is to help the patients. But I think patients can sometimes perceive it like this, and Alison herself talked about how she wondered if she was a victim of torture. Be that as it may, intensive care is undoubtedly an extremely stressful environment to find yourself in. It's very noisy, there are alarms going off, beeps going off. They seem to have special metal bins whose lids clank away all night, waking the patients up. You're connected to machines, tube lines, all sorts of things that can be a very alienating experience. The design of intensive care is often very harsh and stark and clinical, without anything sort of comforting or homely to look at. The light can be very unnatural. There's often no windows for some reason in intensive care. So you do see these kind of gloomy light that you see in those pictures. And that is contributing, I think, to the loss of day-night cycle that patients experience, and therefore they become unable to sleep due to a number of factors, not just the environment. A lot of patients say the worst thing is their inability to communicate, and that's for a number of reasons, including when you're ventilated, you're intubated, and so you have the endotracheal tube down the back of your throat and you can't speak. You may then, for your comfort, be given a tracheostomy, but for a long time with a tracheostomy you may not be able to speak either until a certain point where you can be given a special speaking valve which helps that situation. And that combined with general weakness of the hands and so on, it's not always easy to write or use communication charts. So that is one of the massive stresses, that no matter what you're going through, you can't really tell people what you're going through. A lot of patients are nursed in open bays in intensive care, sometimes side room, but often open bays, and then you're seeing other patients around you. You might hear them shout out, you might hear them in great distress. And sometimes, unfortunately, patients do witness other patients dying. And you're aware of their families, their relatives who can get angry, upset, they're grieving. So all these things, you're a bit trapped in the bed, witnessing all of that going on around you. You're also most people in intensive care are having a lot of invasive procedures happening to them. And there can be multiple invasive procedures every day, so maybe people are being, multiply traumatized by that. And finally, a lot of patients in intensive care are really being given quite a cocktail of psychoactive drugs, from opiates, sedatives, anxiolytics, anesthetics, adrenaline, noradrenaline, antipsychotics. And I think these drugs can really contribute to clouding the consciousness and changing the way you perceive what's happening around you and to you. And there's quite a lot of work suggesting that the drugs in particular, as long as with some of the other factors, are contributing to the high rates of delirium that you find in intensive care patients. So, as you know, delirium is an acute confusional state caused by a physical condition, medication, or a toxin. This is a diagram by Maldonado, and he looks at the 5 main domains of delirium. which are, as you know, impairments of consciousness and attention, which are really the cardinal feature of delirium, a global disturbance of cognition, affecting all domains of cognition, perceptual distortions, hallucinations, delusions, memory impairment. Psychomotor disturbance, so some patients become very hyperactive, whereas others become very hypoactive. And then there's also, you can have a mixed picture of the two types of delirium. Emotional dysregulation with irritability, fear, perplexity. And as we've mentioned, disturbance of circadian rhythms. So this condition has been found in up to 80% of patients who are ventilated in intensive care, and even in non-ventilated patients, up to 50%. It was very prevalent during COVID. The COVID patients in ICU, up to 73% of them had delirium. And I think COVID was a situation that was it was like a factory for delirium, actually, or the conditions were so poor. And often delirium's just regarded intensive care as something that just happens, it's just one of the byproducts of being there. Doesn't really matter because we're saving lives. But in fact, it does have serious outcomes. It leads to longer admissions to ICU and hospital, increases risk of mortality, and there's a very firm association with delirium and longer-term cognitive impairment. This is an interesting retrospective qualitative study of patients called vivid plasticine people, which was what one person said they found, by Derbyshire. The themes were sense of isolation, paranoia, blurred reality, and then trying to make sense of what was going on. Some of the examples that you hear very frequently from intensive care patients is they believe they're traveling a lot, they're in a bed, but they believe they've been going all over the world by boats, planes, trains, and spaceships. Abduction is another very sad theme where people think they've been kidnapped by aliens or gangs and imprisoned. Dehumanization, one person said they felt like a lump of meat on the butcher's table. Another said, I felt I was a washing machine plugged into the system, probably because they're surrounded by all this equipment and attached to all this equipment. And often paranoia, where the patients believe that the staff are actually trying to kill them. I thought the doctor was trying to kill me, trying to switch the tubes off that were feeding me or helping me to breathe. This was a study by myself and colleagues where we sort of analysed accounts of hallucinations and delusions that patients had in intensive care. And this was, we had a cohort of 157 patients, and 27% of them had post-traumatic stress disorder or serious sort of scores on PTSD questionnaires. Of those, the majority had, the flashbacks that they had were of nightmares and hallucinations. Far fewer had flashbacks or memories of real events that happened in intensive care. And these flashbacks were very persecutory and bizarre images of cults poisoning, staff stealing their blood or their organs, being tortured and turned into zombies is very common. David Aronovich, the well-known journalist, writer and broadcaster, was in intensive care, I think about 10 years ago now, when he went in for a day surgery for a minor bowel operation, but had complications and became much more seriously ill. So he talked about delirium. He says, the 5 nights of delusions and delirium in intensive care were the most terrifying nights of my life, bar none. Patients in intensive care are terrified out of their minds. If there's something we can do about this, we should do it. So this was a bit of a challenge to us working intensive care. We thought, yes, we should be doing something about it. So what role can health psychology play, both clinically and in terms of research that we can try to throw more light on the problem. We were really aided by NICE showing sort of considerable recognition for the fact that rehabilitation of ICU patients should be for the body and the mind. So this started with their clinical guideline on rehabilitation after critical illness in 2009, where they recommended that patients should be assessed for risk of psychological morbidity and given psychological support to aid rehabilitation and recovery. Then in 2017, they published their quality standards, saying that psychological assessment and support were key at 4 key steps on the sort of critical care patient pathway. And it's now enshrined in the Intensive Care Society staffing guidelines that all intensive care units should have a senior practitioner, psychologist, and team to provide patient, family, and staff support. I mean, in fact, we've now got ICU psychologists in about a quarter of ICUs, so we're not quite meeting the standards yet, but it's a big improvement. So what can psychologists do? Well, there's all sort of 4 main stages of the pathway. So very early in intensive care, it can be about helping to communicate with delirious patients, promoting more holistic person-centered care in the intensive care unit, and particularly giving families support and information to families about the delirium and what's going on. A bit later, intensive care, when the patients have hopefully woken up, we carry out psychological assessments and then psychoeducation for the patients themselves, for example, about the causes and symptoms of delirium. Because often the patients think, you know, what's happened to me, I've gone mad. So it's really important to address how they're thinking about their experience. Later on, step downwards, after they leave intensive care, that can be a really good time to reflect on difficult experiences and memories. And we can introduce some cognitive behavioral techniques to help them in their rehabilitation. And then after hospital, we've set up peer support groups, follow-up clinics where we can offer evidence-based therapies for anxiety, depression, PTSD, cognitive assessment, and make new referrals for neuropsychology where necessary. So in all of this, I suppose we've worked with evidence-based therapies, but they're not really specific. They've not really been evaluated in ICU, so we are trying to work towards interventions that we can evaluate in the intensive care setting. So we knew that acute stress was a key risk factor, as I mentioned before. So one thing we did was developing this ICU psychological assessment tool, which is quite an easy tool that nurses use in the ICU, or psychologists, but quite often nurses, just to assess things like mood, experience of disorientation, hallucinations, and delusions. And that was validated and published in Critical Care Journal. We carried out a systematic review looking to find out what early interventions have been tried to reduce acute intensive care stress. And we identified 23 studies of psychological interventions such as talking therapies and also giving patients diaries, using music and nature sound therapy for patients on ventilators, and also using mind-body type relaxation practices, therapeutic touch, visualization. So about half of these showed benefits, so we thought, well, it did look quite promising, these early interventions for acute stress. So this then led to the POPPY study, an intervention to reduce aiming to reduce post-traumatic stress disorder. And this was an evaluation of a complex nurse-led preventative intervention. Had 3 main elements. One was to encourage staff to promote a more therapeutic environment in intensive care. That was for all patients. And for patients that we identified as being acutely stressed using the assessment tool, nurses would then deliver 3 stress support sessions, as we called them, and those patients would also receive a relaxation recovery program on an iPad. And that was our results paper that was published in JAMA in 2019. So more about the trial. It was a cluster randomized clinical trial in 24 NHS hospitals funded by the NIHR. There were 12 intervention sites and 12 controls, and the primary outcome was PTSD at 6 months. So the results were we recruited 1,453 patients, and we managed to follow up 80% of them for their long-term psychological outcomes. However, we found that our intervention did not make a difference to the primary outcome. There was a large decrease for those who received the intervention, there was a large decrease in their anxiety from pre to post intervention. However, that was not measured in the control group, so we can't really read too much into that. And we also carried out a process evaluation, and we found that many of the patients that we felt could have benefited from this intervention were excluded because of lack of capacity, because it was a study where patients had to have regained capacity to participate. But of course, many of the patients have persisting delirium, so never did regain capacity in time to be recruited. And we also found there were many barriers for nurses trying to deliver this intervention. They found it quite stressful to do. They had to combine it with a normal clinical role, and many of them didn't find it an easy thing to do. So the lessons from that for our sort of future research is we now think we do need to evaluate these interventions led by psychologists, at least in the first instance, to prove the principle that they would work, and then potentially be able to train other staff in them further down the line. There was something about the timing of the intervention. We think now it might have been better to intervene earlier with psychological support to reduce distress from delirium, hallucinations and delusions, which would mean, other studies we're planning, we think we will get surrogate consent, which patients can confirm later, so that means that we could work with delirious patients. Or is it better to intervene later? And there's some preliminary work going on evaluating using eye movement desensitization and reprocessing, otherwise known as EMDR, post-ICU PTSD. Okay. So just to summarize, up to half of patients have a very poor psychological recovery after intensive care. Many suffer acute stress and delirium in ICU with early traumatic memories. Psychologists are beginning to intervene to reduce the risk factors and improve psychological recovery. And there's ongoing research to develop and evaluate better psychological interventions for intensive care patients. I've got a couple of slides of references which anyone who's interested can ask me for. And thank you very much for listening.
Dorothy, thank you very much. Really fascinating and thought-provoking. We've got time for a couple of questions. I wonder, so we've got
this one here
in the middle, and then in the middle first. All right.
Hello, very interesting. I'm a liaison psychiatrist working in a hospital very close to you that doesn't have a psychologist for ITU. One comment, which is that I think you can add your trial to the very long list of interventions to try to reduce PTSD that have proved to be unsuccessful. So you might want to think about having a different primary outcome, because there's a lot of bad things going on that aren't PTSD that you might be able to prevent. And then my question is, we get asked to see a lot of patients who are extubated, become agitated, get re-intubated, get extubated, become agitated, etc. And that seems to me one of the worst experiences for patients on ITU. I think when you've got anaesthetic agents and an ability to ventilate people, that's what ITU physicians do. Is that something that comes out in your research or your clinical experience, that sort of cycle of being re-intubated?
You mean the experience of being re-intubated several times? it's something that patients have mentioned and something that I do observe is obviously a really difficult experience. I don't think there's been a specific research study looking at that, but it's a very common experience. Because obviously the emphasis is to try to extubate patients because that will resolve a lot of problems, but often, doesn't always work and they have to re-intubate them. So that's a really difficult experience for the patient. Does that answer your question, or was there a... I see what you mean. Yes, yeah, that would be good. Because I think what happens when patients are agitated, then they just tend to resedate them and then ventilate them. But I think if we could introduce more training for other ways for staff to manage agitation without necessarily using a pharmacological approach, that would be really good. Sorry, I've got lights glaring in my eyes, so I'm having to shield my eyes.
Thank you. Paul?
Yeah, thanks for a really interesting talk. I'm also a liaison neuropsychiatrist, so I've seen quite a lot of these patients over the years. The first part of my question, I suppose, is related to the last one about how much of this do you think is related to sedation and type of sedation used, and should that be being looked at in research? Perhaps different agents or different levels of sedation should be considered to try and reduce this problem, because it is a really big problem, and people have these memories and delusions that persist for years, and it really affects outcomes. And the second thing I was wondering is, do you think there's a role for psychiatric medication such as antipsychotics in the treatment of persistent delusions in this patient group?
So in answer to the first question, there is a lot of research going on looking into different ways of sedating, different agents for sedation, sedation hold, sedation interruption, moving away from benzodiazepines. Yes, I think these outcomes, but also it affects all types of outcomes really, because the longer patients are sedated, they're also immobilized, so that leads to longer physical problems. So it's the physical problems, the psychological problems. Yes. So yeah, there's a lot going there, but I don't think they've really come up with any great. I mean, I don't think they found better agents necessarily, but what they're just finding is that sedate for as little as lightly as possible for as short a period as possible. In some cases, they've actually used no sedation protocols. I don't know what that's like for the sedate. Yeah. And antipsychotics, yes. I mean, there's actually a massive use of antipsychotics in intensive care units. In the recovery period. Yeah, I don't know of anyone using antipsychotics in the recovery period, but I think they're overused in the intensive care unit. Because that's the sort of treatment of choice for delirium, let's just have them on antipsy. So when you look around, nearly everyone's on some antipsychotic or other, even though there's actually no evidence that those are effective with ICU delirium.
Folks, I think we've got time for one final quick question.
There was
Lawrence,
somebody down here.
I think here.
Hi. So delirium is obviously very common on general medicine within the hospital, outside of ICU, and obviously some of the factors about intubation and ventilation are specific to ICU, but some are more common, in terms of sleep and medications and lack of agency. So I was wondering, do you and interventions to improve that, I think, are very hard to implement more broadly. Do you think there's any kind of lessons from the trials or from trying to implement a service that maybe people could apply elsewhere in the hospital?
For the rest of the hospital? Yeah. I think it's a bit more the other way around, because I think there's been better research into using non-pharmacological treatment bundles for delirium across the hospital. And we haven't done very much of that research yet in ICU. So I think there's quite good evidence that those non-pharmacological programs work well. And I think we're hoping that we can apply that to intensive care as well.
Thank
Okay.
Fantastic. Dorothy, thank you very much.